Hello, I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia, and I'm just back from Digestive Disease Week 2023 held in Chicago, a bevy of information, and I'm going to profile this in two separate discussions with you because there's such a significant amount where I thought were practice changing or on the near horizon practice changing implications that I wanted to make it easier for you to access it in a sequential fashion rather than to put it together in one derivative of a discussion that might be 20 minutes or so. So let's make it a little bit shorter. You can go back and forth and look at this in two separate viewings. So let's start with viewing number one. None of these are done based on particular ratings or my highest ratings for the implications of what would change practice, but look at both snapshots as you have time. Let's start with the first part. Let's talk about the study first, initially the outcomes in patients with cirrhosis and left atrial appendage occlusion device intervention. This is the Watchman procedure. We see this in our patients with atrial fibrillation, but notably in patients with cirrhotic, the interventional cardiologists and the surgeons that are backing them up are concerned about this, and we get asked to risk profile and whether or not they should even undergo this. This is a review of 207,000 index hospitalizations for patients with cirrhosis and atrial fibrillation. And these patients that had the Watchman device, approximately 760 or 770 of these patients had the Watchman device. A total of nearly 15,000 patients died during the principal hospitalization, but none in the patients that had this Watchman subgroup evaluation. When they were subgrouped as it relates to cirrhotic grades by Child-Pugh scores, there was actually no difference as it relates to child's classification from A, B, and C, and the GI bleeding risk was lower. The patient's hospitalization, rehospitalization, length of stay, all of these were improved, and in fact related to the patients undergoing this device intervention. So please don't use this as a discriminant in a negative way, and should not deter clinicians from performing this left atrial appendage occlusion procedure in patients with compensated cirrhosis and atrial fibrillation. Next was the cancer risk after polypectomy in patients that were FIT positive in colon cancer screening evaluation. This is a Dutch study that went over 6 years, and they looked at the particular metachronous cancers diagnosed after 6 months of their baseline colonoscopy. And they looked at nearly 255,000 patients that had colonoscopies. The median follow-up was 3 years. And they looked then for particularly metachronous colon cancer, and the hazard ratios that were identified were particularly related to patients that had index findings of advanced serrated polyp lesions with or without the presence of advanced adenomas, or patients with advanced sessile serrated polyps without advanced adenomas. But again, this means that those patients that come in with those derivatives need to be watched in particular very closely. Take a second look when you're doing this, in particular as you find these lesions, look again hard. Make sure there's nothing left behind and missed lesions. So again, may change how we change the follow-up intervals based on the predictive findings, and more restrictive post-polypectomy surveillance guidelines. We'll wait and see where this transfers into the national database. Two studies as it relates to gastroparesis. First was cannabidiol, looking at its efficacy in adult gastroparesis. This is a randomized placebo-controlled trial led by Dr. Michael Camilleri, his colleagues from Rochester. Recognizably that medical cannabis is something that's used to relieve nausea and pain, and the non-selective cannabinoid receptor agonist, dronabinol, we probably all used in patients, particularly I've used it in patients with gastric symptoms in patients that the oncogenic in patients related to cancer. But recognizably it delays gastric emptying, but it does enhance gastric accommodation. The question here is whether cannabidiol, which is selective agonist, has limited side effects of the central nervous system, would also modulate effects of these as it relates to sensation. And this is the study. They looked at an FDA-approved oral formulation of a purified cannabidiol, 100 milligrams per ml. They were looking at a 4-week horizon here, up to 10 milligrams per kilogram a day, using a dose escalation by FDA guidance. And looking at cardinal symptom indices, they found in 29 patients who were idiopathic gastroparesis, 6 were type 1 and 6 were type 2. They improved all the tolerance symptoms and the ability to tolerate a normal-sized meal as it relates to improvement based on this cannabinoid involvement. So again, I think this is a pretty easy one in patients with gastroparesis to look at. so commercially available. It's certainly something that we could try, I think, on the short term. The other one was as it relates to buspirone in early satiety of patients with symptoms of gastroparesis. This comes from the National NIH Gastroparesis Clinical Research Consortium, and they looked at the use of buspirone. Recognized this is a 5-HT1 receptor agonist, and it's reported to improve fundic accommodation. This is a 4-week multi-center randomized trial looking at patients with symptoms of gastroparesis, about actually had delayed gastric emptying. 39% were diabetic. And they found that when they looked at the overall symptoms, they were not improved. But the subset was quite striking as it relates to the secondary post hoc analysis, that there was suggestion of buspirone 10 milligrams 3 times a day was significantly better as it relates to patients with more severe bloating. So this should, I think, be considered very low downside in this in patients with moderate severe fullness and symptoms of severe bloating. There were multiple studies as it relates to computer-assisted development of improvement for colonoscopy use. So this advanced artificial intelligence, talk about revolutionizing endoscopy in so many ways. But there were several that were kind of a breaking fact that maybe it isn't quite needed as in all regards. I'm only highlight 2 of the negative ones and then 1 of the positive ones. 2 were negative as relates to overall improvement significantly. One was by Dr. Yuri Audubon and his colleagues at Stanford, looking at 1,000 plus colonoscopies, and they had 24 endoscopists. There was no significant effect on artificial intelligence and adenoma detection rate. The second was from Spain, and this is looking at patients that were in a multi-center parallel controlled randomized trial. These are patients that were FIT positive, and they looked for advanced colon lesions. They did not differ between the 2 groups, with or without the advanced imaging. And there was some benefit as it relates to serrated lesions that were small, less than 5 millimeters, and large, 10 millimeters or greater, and serrated polyps. But overall, these are patients that were being evaluated by high-level detectors. So 62% was the adenoma detection rate. But again, these are FIT positive, so it should be higher. But again, a negative as far as relates to do we need it in advanced adenoma detectors? Probably not. The one that suggested we would have some benefit as it relates to endoscopists in training. This is a study from Hong Kong, and this is a single-blind parallel group study. They looked at 766 patients, and real-time artificial intelligence improved the endoscopists in training. Right and left-sided lesions, flat lesions, advanced lesions were no different in advanced adenoma detection, but sessile serrated lesions were improved. So again, in the trainees, this may have a significant low-hanging fruit, if you will, on improvement, recognizing where they come from as far as low adenoma detectors to start, but in training. A very interesting study that was led by Dr. Bill Che as a randomized parallel group of self-administered digital gut-directed hypnotherapy versus muscle relaxation and irritable bowel. Recognized that the whole field of cognitive intervention in functional diseases is really been underutilized, but overly promising now as we look at new therapies. And this is a gut-directed hypnotherapy, which was been demonstrated for treatment of irritable bowel syndrome, but access has been limited. And there was some suggestion that muscle relaxation treatments may also improve these patients. So this is a self-administered digital gut-directed hypnotherapy. It's a commercially available, and Bill was kind enough to share the link, and I'll provide this in the reference section. That's by prescription only. There's cost involved, but it's max cost, I guess, in the lack of insurance is $75. But it was compared with digital muscle relaxation, and this is a randomized, and the first randomized controlled trial to assess this. And there was strong support that this was advantageous, something patients could do at home. Obviously, diminishes some of the interventions, real healthcare provided interventions. Being in present, but again, very, very promising, simple and easy with minimal cost, but on the short term, I think very easy to administer. And finally, on PCABs, this is a potassium-competitive acid blocker. This is something that's very promising. The one first in the class in the U.S. will likely be vonoprazan. There's 7 in the class in various stages around the world in development, but it's been approved but not evaluated and released by the FDA for double drug and triple drug for H. pylori, and it's presently under review for erosive esophagitis, where the data is strikingly favorable. A little bit of a hiccup there because of nitrosamine detection, very analogous to what we saw with ranitidine, but again, the FDA is valuing this with the sponsor company. But this is a particular study now looking at the use of oral therapy versus IV PPI for prevention of high-risk peptic ulcer bleeding after successful endoscopic treatment. So the standard, as you would well recognize, for patients when they come in with GI bleeding, we typically will put them on a IV PPI, pantoprazole 80 milligram bolus, followed by an 8 milligram per hour infusion for 72 hours continued, and then BID PPI for the next 28 days, respective of what they have, and then certainly then longer if needed. But the idea of giving them an oral therapy and not using the ICU and potentially the IV administration is certainly a very promising one. This is vonazepam, then administered 20 milligrams daily for twice a day for 3 days, and then 20 milligrams daily for the next month. And the primary outcome here was rebleeding within 30 days. There was no difference here. It certainly, they didn't look necessarily to show an improvement in discharge. This is something that didn't really meet the criteria, but I think more and more people become comfortable with it. But certainly accelerate the discharge from patients coming in with GI bleed. No transfusion. Major differences. They were actually numerically lower in the vonazepam group. So stay tuned, but certainly something on the short term if and when it's ultimately approved in the United States. So the end of part 1, lots of data to share with you on part 2. Make sure you turn in on the next. I'm Dr. David Johnson. Thanks again for listening.